I'm trying to mitigate the damage of my habits to enjoy my life while making it as pleasure as possible. Every day, diet and exercise. I think that exercise is like the key to life. People love this. Every week, I tell them that they should get a body massage because it increases blood flow to your skin, increases blood flow to your muscle. It's physiologically relaxing. It's so beneficial. The answer is just live your best life. Enjoy it. Have fun. Live it to the fullest. And as long as you don't kill yourself, it's going to be great.
I'm Dr. Esra, and I've been living a sober life for the past 19 years. My battle with addiction drove me to seek new methods, devices, and supplements to improve my physical and mental performance, enhance my quality of life, and ultimately live healthier for longer. From my experiences in addiction recovery, biohacking, and longevity to the latest global developments, from groundbreaking entrepreneurs to expert academics, the conversations I've had over the years are now featured weekly on Soberhead Podcast. Welcome to Soberhead Podcast. This is part 2 of our chat with Dr. Sandra Kaufmann on her How Not to Age plan. Last week, we covered the first 3 of her 7 tenets. Today, we finish the set. Tenet 4 is quality control, how cells repair broken DNA, proteins, and take out the trash through autophagy. 5 is immune balance, with a cranky immune system, drives chronic inflammation, infections, and cancer risk. 6th is individual cells. Each cell type, brain, bone, skin, has its own lifespan and nutrient needs. And last, but the most exciting one, is waste management. Looking at advanced glycation end products like stopping sugar-made junk and other debris from clogging cells. Plus, Sandra's clever trick for enjoying sweets without the damage. Haven't heard part 1 yet? Give it a listen first, so the full roadmap makes sense. A huge amount of people who watch Soberhead frequently are not subscribed. So I will ask you a quick favor. Hit that subscribe button now, because when you subscribe, it helps us to make the show better and provides better access to the world-leading experts. I'd like to thank Gedik University and Gedik Foundation for their trust in Soberhead Podcast. With their support, it is possible for us to bring you this content at this quality for absolutely free. Our host for this episode is .sub, the space, community, and platform where creatives, experts, and entrepreneurs come together at the meeting point of continents, the Bosphorus. Follow the link in the show notes for more information about events and membership. Subscribe, like, and share, and I promise to continue to bring you a better Soberhead every day.
We did pathways, we did quality control. Then I talk about inflammation. If you look at DNA repair pathways, and this is so interesting, there's stuff that fixes small errors of your DNA. That's Burr, and then there's NER. So there's base excision, and then there's nucleotide excision. And then there's when your DNA, like the double-stranded damage, there's homogeneous and non-homogeneous, and then there's mismatch repair. But what's kind of interesting is most DNA is the smaller stuff, right? You have 10 to the 5th DNA errors per cell per day. And you have to fix it. And as you get older and these mechanisms fail, you have more DNA damage leading to morbidity and, ultimately mortality. But what's really interesting about like the nucleotide and the base excision, which is just fixing small parts, is that generally comes from UV radiation damage, so sunlight, right? And the question is what can we do to increase the repairability of our DNA from sunlight? And this is where my plant physiology sort of comes, right? I love this. So there are tropical plants out there, and they can't move, right? Plants are pretty set, like their roots are down, they aren't going anywhere. So, right? So the sun pounds them, and they're like, millions of years, what are they going to do? They're going to figure out how to repair their DNA like more quickly because they have to. So there are some chemicals in plants, and we can eat those plants and make our DNA repair faster. So one of those plants is called Polypodium. It's a tropical plant, and you can buy it on Amazon as just as Polypodium or as Heliocare. And it's demonstrated to increase the repair of our DNA secondary to sun damage. I just think that's insanely cool.
Okay, so does it repair the skin mostly?
No, this just repairs the DNA. So if you plan on, well, it goes all over your body, right? But what you're going to sense is that you're going to you're going to heal faster from sunburn, and you're less likely to get DNA damaged skin cancer. Right? I mean, I can't say you're not going to get skin cancer, but it reduces relative risk.
Sure.
No, so what's really cool is if you are going to sit out in the sun, and I live in Miami, right? And I'm pale as pale could be.
Yeah, you're very pale.
So what we do is I take free radical scavengers, because as the sun comes in, right, you get a ton of free radicals. Free radicals causes inflammation. It causes DNA damage. It causes peroxidation. It causes just a whole litany of horrible things. So if you are on oral free radical scavengers to block the damage, and then you take things to increase the repair of the damage, your skin does so much better.
Wow. Yeah, it shows. If what I see from the camera is your real skin,
it's pretty real. I don't have a whole lot of skin issues.
And I know that you do exosomes, so
gosh,
that helps.
Oh God, I love exosomes. The gift of the gods. Anyway, so that's quality control, and then there's tenet 5. What are we on? Yeah, 5 is it's your immune system that becomes your inflammasome over time, right? When we're young, we have protection against pretty much most pathogens, and as we get older, that fails. And these cells just become chronically inflamed. So as a consequence, we have, our inflammasome goes up, and it's called inflammaging. So controlling that is extremely important. Let's see. And then tenet 6 is really...
No. Let's stay on this a little bit, because I know that you have multiple medication, supplements, whatever, to control that glycation.
Oh, no, we haven't gotten to glycation yet.
We didn't come... okay.
No, glycation's like the coup de grace at the end. But my favorite thing for systemic inflammation is curcumin. Curcumin by itself isn't good enough. It has to be sort of souped up. And so people say, I take turmeric. Is that good enough? And the answer is no. Because a small amount of turmeric is actually curcumin, and curcumin in the body has a very low bioavailability. So if you eat straight curcumin, it's not going to do a whole lot for very long. So there's companies that keep making it sort of better and better and better. And at the moment, I think the winner is something called metacurcumin from a company in the States called Repurposing. But every time I say something like that, then a company comes along and says, oh, no, I've made mine even better. But the idea is a bioavailable curcumin should be essential to anyone's longevity protocol.
What else you use for inflammation?
Oh, gosh, I do so many things. So here's an interesting one. Everyone should be, unless there's a reason not to, a baby aspirin. Baby aspirin is known to be very anti-inflammatory. Additionally, it is an iron chelator. And I am convinced that as we get older, we are all sort of plagued with intracellular iron toxicity. So even if your blood studies tell you that you're deficient in your bloodstream, your body stores iron in your cells, and that causes more free radical production via the Fenton pathway. Anyway, so if you take iron chelators that can get into your cells, you can get rid of some of that. And there are studies that suggest, well, number one, this is sort of interesting. If you look at older people with cardiovascular disease that have been on aspirin for more than 2 to 3 years, there's a significant proportion of them that get iron deficient anemia. Because it's binding the iron. So it might be bad for them, but honestly, it's good for us. There's also studies that suggest that the entire anti-inflammatory aspect of aspirin may be due to the fact that it chelates iron, which precipitates inflammation.
I'm taking baby aspirin. They gave it to me because it helps krill oil to methylate better or something. Yeah, there was a synergy between the krill oil and baby aspirin.
Yep, there's, I had not heard of that one, but there's a lot of synergisms out there. But unto itself, aspirin reduces not only inflammation, cancer risks, known to reduce colon cancer. So unless someone has a bleeding disorder or some sort of, reason that they shouldn't be on it, I think it's a great...
Just like one baby aspirin a day would be that much protective.
Yep.
Wow.
Absolutely. Anyway, so that's the inflammatory aspect. All right, so this is so now we're getting to my two favorite categories. So this is,
okay.
So individual cell requirements is really cool. So in every other category, I pretend that cells are identical. This is a category that says, you know what, maybe they're not. So we want to take super good care of our stem cells. We want to eradicate our senescent cells. And we want to say, you know what, we understand that our brain cell is different than our liver cell, which is different than our kidney cell. So this is addressing certain, particular things. And in this category, right, we talk about, so how do we get rid of senescent cells? And how do we make our bones better, right? Because osteoblasts go down with time, which is why one of the reasons that we get osteoporosis.
I mean, there was a good thing in my mind. So we're on the stem cells and senolytics kind of, yeah?
Yep.
In a way.
Yeah.
So first, let's help, like, how do you take care of your stem cells?
So the idea is, which is really kind of interesting. You have a limited number of stem cells. They are going to divide a limited number of times, right? You need to make sure that the niches that they live in are perfect.
Okay.
Perfect. Because if not, you're going to kill your stem cells and then you're sort of hosed, right? And so this is where one of the reasons that I am totally against hyperbaric oxygen.
Yeah, I heard that. Actually, when I was listening to that, guess where was I?
You were in the hyperbaric chamber.
Yeah, but it's because I just recently had the surgery and the doctor wants me to do a certain number of hyperbaric oxygen chamber to make the healing faster.
Okay. Well, so the point of hyperbarics is to bring a higher amount of oxygen to tissues that can't normally get it. Right? So if you have a wound that's not healing, if you are diabetic, right, that have vascular issues, if you've had traumatic brain injury, which basically you've broken all the little microcapillaries, it can be very helpful for those things, right?
Yeah.
If, however, you are completely and utterly healthy, your body does not want extra oxygen. Why? Because extra oxygen kills stem cells. It makes them senescent, right? And it creates more free radicals, and free radicals break up your DNA and they destroy tissues. So assuming you are a normal human being and you want to live forever and you've got no pathology, high oxygen is bad. And I know that people say, there's studies from Israel where we put people...
Yeah, I was just going to come to that.
And what's really interesting about that, Bill Anders and I have had many discussions about this because he's the telomere god, as far as I'm concerned. And when they're measuring telomeres, they're measuring cells that they're sort of circulating in your body, right? And we think, our hypothesis is that the oxygen therapy is basically like killing a lot of the cells floating around. So your body is releasing new baby cells. So when you're looking at the telomeres and you're looking at a profile of new cells that you've made, the telomeres are going to be longer because we think that it is a response to you're killing old cells and you're releasing new cells. And of course, the new cells have longer telomeres.
Do you know the machine called NanoV?
No.
Maybe you want to look into that. It's a German system, and through a structured water, there's a steam coming out of it, and it helps for the protein folding, actually. I was just going to tell you while we were talking about that. But the funny thing is that the inventor and the engineer is German, and they're pretty straightforward with their inventions. They're not like, they just don't try to sell stuff, at least in majority of them. So I was at A4M, not last December, the December before, and I had a dinner with the couple who owns the company, the German owner and the girlfriend, actually. And I said, I'm planning to buy a hyperbaric oxygen chamber, a soft shell. And the guy turned and, why are you going to do that? And I said, well, because I didn't have any specific reasons. And he goes why do you want to push oxidative stress into your cells with that? And at that moment, actually, I changed my mind.
Yeah, he's right. He's absolutely right.
I did a podcast with Scott Scher, and he's one of the hyperbaric oxygen experts. And he kind of is like, the most hyperbaric people is going to hate me to say this, but I say it all the time, everywhere. If you don't need it, whether it's traumatic brain injury or a wound, or you're an athlete, you need to recover, and they don't care to live longer. They care about healing for tomorrow's game. If you don't need it, you shouldn't buy one, and you shouldn't get into one every day.
Yeah, he's right. There's a time and a place for all of these modalities. You just have to sort of figure out, what are they doing, and is it beneficial to me in my present state? And what I found over the course of the research on senescent cells is, if you want to create a senescent cell model, you take cells, be a stem cell, any cell, and you give it extra oxygen, and it becomes immediately senescent. So I think that repeated high oxygen will destroy your stem cell population.
Don't we produce stem cells like every day until we die?
So you have a stem cell population, and they sit in very specific stem cell niches. And it turns out that most of your cell types have their own sort of subpopulations. And they just keep dividing until they can't anymore. And so the more you force them to divide, theoretically, the more you are limiting the pile.
Okay, got it. Is senescent cell in this category or in another thing?
So this is the idea that you must eradicate senescent cells, because I like to think, people call them zombie cells. I call them grumpy old man cells. Because I always envision, the worker that's been there for a while, he just has nothing nice to say about anybody. He sits in the corner. He's fat. He eats donuts all day. He's just grumpy. And his grumpiness sort of spreads to anyone near him. They become sort of grumpy. And then soon you have a whole culture of grumpy human beings. And the reason I stick with this model is because this is what cells do. When one cell becomes damaged, right, it undergoes some sort of DNA damage, and we know that that's a very common thing. The cell shuts down, becomes quiescent. And if it can fix itself, great, right? But if it can't, it can become senescent. And the senescent cell changes. It becomes very fat. The organelles inside become leaky and sort of distorted. The metabolism of the cell changes, and it just puts out inflammatory factors. This is my grumpiness. It's called the SASP, and it just it acts upon cells both nearby and far, and it makes them sort of more inflammatory as well. So it's the one bad apple in a bucket makes them all go bad sort of phenomenon. So as you get older and you have more centers of pathology, you are more and more loaded with senescent cells. And there are absolute studies that demonstrate that if you can sort of get rid of these senescent cells, you do better.
But your first goal, I guess, is not to create senescent cells.
Correct.
Based on your protocol, is just to really reduce the production of it. So to protect your original stem cells so that your body doesn't need to keep producing it, and save them until 100, 120, instead of having a limited amount to multiply, and you start getting a lesser and lesser until when you're 85 years old. It's interesting. I have to make that joke that you made, because or maybe you can do it. You have a funny theory about that an old person should not take senolytics. You say it. I don't want to.
Oh, no. You can steal my fire anytime. No, it's really funny. Like, the older you get, the more all of your cells become senescent. And the running joke is like, don't give anti-senescents to really old people, because they'll just become like a pile of crumbs on the ground. They're just going to go. Anyway, but so following that, right, the idea is to, limit the creation of senescent cells. And it's not just stem cells. Any cell can become senescent. And so if you limit the creation and then you sort of get rid of them sort of intermittently as you go, then you're just going to do better overall.
Speaking of which, I did a program with Robin Rose. She's an expert on long COVID especially, and how she described that these mRNA vaccines and the virus itself, the spike proteins gets into the cell, and then that cell becomes right away a senescent cell. And they start affecting the neighboring cells. Do you have any specific protocol for that?
So the answer is yes. There are, so you have to sort of separate. There are senolytics, meaning they kill senescent cells. There's xenomorphics that change like how a cell acts. And then there's some things that just sort of like stall out the cell, meaning it reduces the release of the cytokinins. So some things can kill them, and that's sort of what I try to focus on, like sort of intermittently. So the famous plans are there's the DQ, right? The dinacetab quercetin strategy, where you give those, 2 products for 2 to 3 days, like every few months. You can do that. Fisetin works. Roxythromycin works. The other thing that's sort of interesting about senescent cells is that they're not all the same, right? Because they come from different cell types. So a bone senescent cell may be different from a fat-based senescent cell. So not one type of anti-senescent medication is going to get rid of them all. So I rotate them. So I will do, DQ 1 month, and then I'll do some, roxythromycin, then I'll come back and I'll do some fisetin, blah, 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 blah. So I just sort of rotate them. But what's interesting about quercetin and fisetin is they do sort of different things at different dose levels. So they're extremely useful for your cells in small doses. So I'll generally tell clients, small dose every day, and then bolus them or give larger doses sort of intermittently to try to get rid of these senescent cells. I
heard, and it may not be the truth, but there was not enough studies about fisetin.
So the problem is that it's not, studies are really interesting, right? People only study something if they're going to make a lot of money out of it, right? Because it's an over-the-counter supplement. It's not a cheap over-the-counter supplement, but it's an over-the-counter supplement. No one is going to sink $100 million into a study demonstrating this if they're not going to get their money back. So, drug products do, right? We know this because drug companies are willing to invest the money, but no one's going to invest the money in supplements to do this, as far as I know. Therefore, you have to go back to baseline, bench research. Does it kill senescent cells in culture and in rodents? And it does. And it does. Okay. Do we know about people yet? No. Should it? Probably.
Yeah.
So therefore, if you're not completely sure and you look at the risk-benefit ratio, if there's no downside to it.
So how do you feel about then if we were going to be, our goal needs to be to protect our stem cells. How do you feel about getting stem cells from outside?
Oh, I'm staunchly opposed.
Why?
So you have to think, so the question is, who gave you the stem cells? If they are your own, right? If you donated them to yourself and they've been cultured and they're autologous, that's great. They can inject them into you and they are you. They can get incorporated into your body. They can sit there. They can make more tissue. They can make exosomes, like fantastic, right?
How about age though?
So that's the thing. You have to get them from yourself when you are younger. Right? It's lovely. It'd be great to go back into time, right? Your cells are younger right now than they will ever be. So if you're going to do it like today. Most people, however, use stem cells from other people, right? When you inject other people's cells into you, various things can happen. Cells are covered in surface markers that can cause immunologic problems. So as an example, if I were to give you a blood transfusion of somebody else's cells, you will go into cataclysmic death, right? You have to have, the labs go nuts about which, antibodies do you have and is it compatible and this, that, and the other. So if you start randomly getting other people's cells, number one, you've got surface marker problems and you're getting someone else's DNA into you. And I will tell you straight up that of the clients that I see that do stem cell infusions or injections, the first 1 or 2, fantastic. They work really well. Everyone's happy. Second 2 or 3, not so great. Down the line, they just don't work very well. And this may not be like everyone's impression, but this is what my patients are telling me.
Why it works for the first time?
Because you don't have any antibodies to someone else's yet, right? But remember, these cells are going to get destroyed. They're foreign. They are not going to go into your body tissue and create more cells. They are not going to do that. they're going to get eaten up in the capillaries of your lungs, in your spleen. Your immune system is going to kill them. So honestly, all you really have when you do this is 4 to 5 days of a release of exosomes. And they're beneficial, right? But the more you do it, the more your body's going to attack them as foreign, the less efficacy that they're going to have.
Like COVID vaccines.
Yeah. Yeah, right? It's very similar. So what I do instead is we just use the exosomes. Exosomes are not cells, they're vesicles. They do have surface markers, but significantly less. There's some DNA in there, it's mostly RNA, but significantly less issues. And you can give them until the cows come home. I've given exosomes to myself, IV, every month for like 2-3 years, and they're amazing.
And you're using like umbilical cord, placental?
I've used both.
Mix?
I used placental for a while. I've now been using a company that uses umbilical cord. You know, they all have their pros and their cons. But yeah, I use perifetal tissue, good companies, quality tested, third-party tested, et cetera, et cetera. But yeah, that's what we use.
I'm sure you heard of Muse cells.
Mm-hmm.
And what do you think of them? Because you're so into exosomes.
Yeah. I think they have their place. I have not sort of played with them yet. But I think they're going to be big.
Okay.
I don't know enough to have a truly like this opinion, but clearly they are on the radar, and clearly I think they're going to be very efficacious.
Okay. Where are we now?
So we get to get this Tenet 7 now, which is fun. So Tenet 7 is what I call waste management.
Okay.
Most of which is glycation, and then of course there's the accumulation of lipofusion. And we'll knock lipofusion out first because that's the easiest. So lipofusion is just cellular garbage. Every time your body or your cell decides to recycle something, which is autophagy, there's always a glob that it just can't break down. And usually it's iron or metal based. And it takes up space. It causes the production of more free radicals, and it's just your cell doesn't know what to do with it. So for cells that you are going to get rid of, it's not a big deal. You're just going to take out the trash. But for cells that are long living that don't turn over, it's a big deal. And the big deal and the big cells in which this category sort of is important is your brain cells. So you don't turn over your nerve cells per se. So as lipofusion accumulates over time, they've looked at brains of very old people, and they're just filled with gunk. And that basically limits cellular function, and it's probably why we sort of lose brain function as we're old. One of the reasons. Anyway, so that's lipofusion. But the big thing in this category is obviously like glucose and reducing sugars. What happens to them? And you can either A, just not take in a lot of glucose, which is great, or B, use my very complex system to overcome glycation.
Yeah, I'm very interested to hear that, because a while ago you explained it's not, for you longevity is not like suffering an agony of doing nothing. Rather, you want to enjoy things that you like. And I think you have a sweet tooth.
I do. I'm terrible. But yeah, I inherited that from my mother. So I set out to figure out, what does glucose do to you? How do we process it? And then how do you block all of those things? And in reality, right, you bring in glucose. And it's not always glucose. It's fructose, all the reducing sugars. And your body processes that molecule, and you create things called AGEs, advanced glycation end products. And these are pieces of the broken glucose that stick to things, usually proteins, but also lipids and DNA. And it causes those to malfunction. So, for example, as we talked about, a protein that works by a three-dimensional ability, right? If you add some glucose on there that shouldn't be there, the molecule's not going to function anymore. Right? Or if you load down glucose onto your protein. I'm sorry, that was proteins. If you do it on your lipids, then all of a sudden they become known as foreign, and then the macrophages come along, and then you're sort of like in foam cell world. And so that's bad. But they cause massive inflammation. They cause tissues to break. That's why collagen sort of falls apart over time. So the question is then, well, how do you limit glucose into the AGE process?
If you eat.
Right. Assuming you eat. And so there's many things you can do. And I do all of them. You can reduce carbohydrates from being absorbed into your gut. Right? Carbohydrates
How do you do
long
that?
chains of glucose, fructose, sucrose, blah, 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 blah. So you can just prevent it. So in your intestinal wall, there's two enzymes. There's alpha amylase and alpha glucosidase. And if you block those enzymes, and most polyphenols do, you're not going to absorb as much. Right? This is what acarbose does. And everyone thinks, oh, it's the next best, greatest. You know what it does? It blocks glucose absorption, but also you fart like a fiend because now your bacteria are eating all of your carbohydrates. And you do, like, you have so much gas. I tried that once. I'm like, this is the worst idea ever. But there are some things like, like chlorogenic acid from coffee, as a good example, that reduces these enzymes, but not entirely. So you're just reducing some of the absorption, right?
Okay.
And then you can keep playing the game. You can reduce gluconeogenesis in the liver, so you don't make any new glucose. You can change what cells it goes into, right? Here's a good example.
Okay.
So glucose will go into nerve cells, and it immediately gets turned into sorbitol, which is very osmotically active, and then fructose. And fructose is 7 to 10 times more glycosylating than glucose.
All glucose turns into fructose?
No, not all of it, but it can. Okay. It's the polyol pathway, but especially in diabetics. So if glucose is high, it goes into a cell, becomes, as I said, sorbitol, which is osmotically active, and then turns into fructose. That's a problem, right? The enzyme that does that is called aldose reductase. Right?
Okay.
So I take an aldose reductase inhibitor. Therefore, even if my glucose goes into a cell, nothing happens.
Are you able to measure it with any of the,
So the answer is, I don't check my glucose because serum...
If you would check, serum is different than...
So serum... So what you have to think about is serum glucose is different than intracellular glucose, right? There's many ways to skin a cat. So there's another drug, right? So aldose reductase inhibitors, that's a drug. It's called a Pilrestat. And they give it to diabetics that are starting to have symptomatic problems. Well, why wait till you have symptoms? Just take it. In fact, a friend of mine at one point was getting sort of nasty cataracts, and he started taking this, and his vision got better. So I'm like, oh, that's pretty cool. But I just take it anyway. And then there's a family of drugs called the flozins. There's canagliflozin and pagliflozin, dapagliflozin, and those are sodium glucose reuptake inhibitors.
Okay.
So the way your kidney works is your kidney filters your blood, right? And it sucks out all of the glucose, right? But your body then says, you know what, we need some of that back. So it reuptakes it. So you're filtering it out and then you're giving it back, which doesn't make a lot of sense, but that's what it does. So what this medication does, it is a reuptake inhibitor. So basically your kidney is sucking out the glucose, but then you don't give it back.
Okay.
You just pee it out. Right? So you can eat whatever you want for the most part. You can't go nuts, but whatever. So it comes into your bloodstream, your cells take what it needs, and then your kidney's like, yeah, we're just going to dump the rest.
Can you take these things based on when you eat, or are they also a daily regimen?
Just a daily thing.
Oh, okay. So you need to build this thing up in your system. It's not like digestive enzymes that you take it before eating.
No. This is just, I guess you could time it, but these are just constant drugs. And these are designed for diabetics. But I have a theory that we're all diabetic. I don't care what your levels are necessarily, unless they're super, super low. But over time, glucose causes glycation, or glycosylation, rather, and that causes problems. So if you can reduce the amounts, you're going to win. You're just going to do better.
Do you have any method to undo what has been done? So
that's a really good question. So that's called Trans-Glycosylation. And when you look at the production of an AGE, a non-enzymatic path, right? So you get the glucose molecule, breaks into some pieces, turns into one of the intermediates, and then it sticks to, there's a shift base, et cetera, et cetera. Anyway, whatever. Non-enzymatically, just naturally goes to become an AGE, right? The first half of those reactions are reversible. The second half of those reactions are not. All right.
Okay.
So in the beginning process, if you throw in a molecule that's more attractive, the glucose will jump to that molecule. So those are trans-glycosylating agents. And the best example is something called carnosine. It is a dipeptide. It's naturally in our bodies. We have less and less as we get older. Women have less than men naturally. So if you take carnosine, you are going to be able to block or limit the beginning of that reaction. Right? But then the question is, well, what happens to the ones that have already gotten through the whole thing, right? What if you already have AGEs floating around? What are you going to do? So then the magic here is that there's a molecule called lactoferrin.
Okay.
Lactoferrin is also something you have naturally in your body, and it's designed to carry iron, like in breast milk and a variety of other tissues, right? But the molecule, it looks like a barbell, and there's 2 binding spots on each side, right? It turns out that you can also bind AGEs on those spots. So I take a plethora of lactoferrin because A, I'm sucking up extra iron stores. I'm using it as a chelator, and I'm also using it as an AGE sponge to sort of clean up whatever's left in my body, and then I pee it out.
Oh, wow.
So it's a sort of ornate process.
I mean, just like, while you were explaining, I'm thinking like when she finds time to get into these details and how the mechanism, you're literally taking the body as a machine.
It's because it is one.
No, I understand it is one, but like you're looking at not as, obviously we're humans, but you're looking like, okay, it works like that, and that's attached to this, and this happens. So if I do this and I can reverse it, it's really fascinating. So that's why you're able to kind of, you want to live until 120, but you're using all these agents and able to kind of do whatever you want.
Yeah. Yes.
Where is Diet Coke falls into these categories?
Oh,
why it's cancerogen?
Oh, God.
And whatever.
So I will upfront say that it is a terrible habit that I have. I would love to break. It's terrible, right? It is. There's one sitting here behind my computer that I have been hiding, right?
But you also say that it's delicious.
Yes,
and I feel
it's
the same way.
It's delicious. I love it. I hate coffee. I should drink coffee, but I can't stand it. So this is what I do badly. I eat reasonably well, except I'm a junk food junkie. I don't drink a lot of alcohol. I do drink a lot of Diet Coke, and it does have a lot of toxins in it. However, I try to chelate the toxins. I try to repair my DNA. I am trying to, just like I would do for anyone else, I'm trying to mitigate the damage of my habits to enjoy my life while making it as pleasure as possible.
Okay, so you use this tenets that you described for Diet Coke. It seems like it taps into multiple.
Oh, yeah.
Because they keep saying, the artificial sweetener in it, it's really bad. How do you feel about that? Do you really think it's horrible?
I think that everything that we seem to put in our bodies these days is slightly inflammatory. And anything inflammatory causes cellular dysfunction and ultimately cancer. They all do it. The air we breathe these days is toxic. Like nothing that you truly are consuming. I mean, unless you live in Iceland on a ranch or something, everything's sort of pseudo-contaminated with the microplastics and the this and that and the other. So the world is not the clean place. So even when people say they're eating clean, I don't really think you are, right? It's just, we're all on the spectrum of what crap we put in our bodies, if it's a little bit or it's a lot, right? How do you get rid of that is the question, right? Some people try to mitigate it, try to chelate it if it's the heavy metals. I haven't done it yet, but I want to start doing plasmapheresis to sort of clean the crap out. There are, the problem is you just can't lead the perfect life. And I think a lot of people are afraid of longevity because they think they have to, which is why I honestly go out, of my way to say, I am not perfect in any way, shape, or form, right? I'm supposed to be one of the world's experts, and I do these terrible things to myself. But the answer is you learn how to mitigate the damage.
When I was listening to one of many of your stuff, I was curious and I was thinking in my head, what do you think of GLP-1 agonists? Because you're using some other stuff for these glucose intake. Then now I understand it's not like you're not focusing just into the serum spikes and stuff, but you're trying to find a different way to get rid of it before even it affects your cells.
Mm-hmm.
But how do you feel about them?
I think the GLP-1s are brilliant. I mean, basically, I've tried them myself. So number one, they just make you not eat things, right? They make you not hungry. And so as a consequence, your inflammatory system is sort of calming down. Like all of the foods that people eat when you're, obese or overeating, bad for your cardiovascular health. It's bad for your immune system, your inflammasome, all of those things. So everything is going to improve if you can control what you eat. On top of that, there seem to be a lot of sort of new cellular processes that are sort of coming out of research with the GLPs. That being said, that there are some natural GLPs out there in various foods that you can sort of eat as well. That being said, I microdose GLPs. I do a little bit every, couple weeks, sort of just for fun. I think they're useful. I don't think they're the answer. I don't think that any one thing is going to be the answer. I think because you age for many, many reasons, whatever we do, it has to be multifactorial to fix it.
Now that we went through all 7 tenets, if someone comes to you and they're not really willing to take 70, not even 50, not even 20 supplements, do you have a base core suggestions that will kind of tap into all of these a little bit?
Yeah, no, absolutely. So someone asked me that question, I don't know, 7, 8 years ago. So I designed what I call the Panacea.
Okay.
And it's only called the Panacea because that's kind of what the letters spell out. Like, I don't want anyone to think they would save every problem in the world. So the P in Panacea stands for pteristilbene, and it's because sirtuins are so important. So pteristilbene or resveratrol, along with other things that they do, but their main key in this sort of program is sirtuin activation. So that's one. The PA, A stands for astaxanthin. Everyone needs a lipid-soluble free radical scavenger. Reduces DNA damage, reduces oxidative stress on your LDLs, HDLs, reduces all sorts of cool things. So that's key. PAN, N is an NAD precursor. We talked about how important NAD is. And then the 2 C's. C for carnosine, which is the dipeptide for trans-glycosylation. And then the other C is curcumin for your inflammatory issues. So what I do is anyone over the age of 40 that doesn't have specific complaints, I put them on those. We wait a month or two, and then we add other things. Because once people are on that package, they know that it's beneficial. And at least I know I'm hitting most of the tenets.
And you're big on pharmaceuticals, microdosing, kind of.
So I am. Why? Because I'm an anesthesiologist. I'm a physician. I use drugs every day. They are FDA approved in their production, their manufacturing. We know exactly what they do. We know what the side effects are. We've tried them out on hundreds of thousands of people to get the side effect profile. We know that what you're getting is exactly what you're getting, right? If you eat a plant, sometimes it's not exactly what you think you're going to get, right? There's very limited control of all of the supplements and manufacturers at this moment, right? Some are third-party tested, some aren't. What are you actually getting? Blah, 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 blah. Pharmaceutical, you know exactly what you're getting, right? So if you think about it as well, they're just molecules. Did the plant make the molecule? Did some dude at AstraZeneca make the molecule? It doesn't matter. It's a molecule, and a molecule works via molecular mechanisms for biological change. So I don't care, to be honest, where it came from, as long as it does what we think it's going to do. It's just in terms of safety and knowledge, we know what pharmaceuticals do more than anything else. So yeah, I am a big fan of pharmaceuticals.
What are the ones that are not really? Because you're using, when I look to your list, you're not using, I'm sure you're using them as well, but with most of the things that you talk about is not very typical that most doctors suggest their patients to take as second purpose drugs, such as naltrexone, Viagra, whatever is the actual name, I forgot. There are a couple of more, but you're using like a more sophisticated, interesting compounds.
Yeah. Well, so the answer is, naltrexone is a naloxone reversal agent. So we use that in the world of anesthesia, and it does reduce inflammation to a certain degree. Is it better than other anti-inflammatories? I don't think so. Right. And as an anesthesiologist, my fear is, oh my God, someone's having a horrible traumatic surgery. They're in a bus accident and they come in there on naltrexone. narcotics aren't going to work for you because you're on the reversal agent. So I don't necessarily think that's the best thing to do. You talk about Viagra or Cialis. Those are PPIs. They're phosphodiesterase inhibitors, right? And they have specific half-lives and blah, 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 blah. I absolutely use phosphodiesterase inhibitors. I just use a different subtype with different pharmaceutical capabilities. So some of those things are right and some of them are wrong. And, I also don't listen to anyone else. I mean, that sounds snooty. I don't listen to Joe Schmo's physician's suggestions because I don't know where he got his ideas. I go straight to scientific literature. What problem do I want to solve? How do I do that, right? So, for example, I tell people to take pioglitazone. It is an old-fashioned hypoglycemic agent. It's a medication. Why do we take it? Because it's a PCG1 alpha agonist, and that upregulates your mitochondria.
I saw that. Is that the one that is like for like a fat to brown fat?
Yeah, well, no.
Am I making shit up?
So it redistributes your fat. It actually causes your visceral fat, which is known to be quite dangerous, to your subcutaneous tissues. So it's redistribution, which is fantastic. Sometimes it tells, some people gain a pound or two, but honestly, the PCG1 alpha agonism there's so few things that do that. I think that's crucial to mitochondrial health.
So you said it takes from the visceral fat and distribute as a subcutaneous fat?
Yeah, right.
Wow.
And as we get older, right, we get visceral fat and then we all look like skeletons because we don't have any sub-Q fat. So then we all get spillers in that garbage, right? So this just does it naturally. It's fantastic. And there's a lot of drugs that do these things. What I do is I look at the molecular mechanisms. What do they do? Is it beneficial? What's the risks? And then you sort of figure it out. So I don't have gout as an example, right? I don't. But uric acid, even at low levels, are inflammatory, right? So I take half of a dose of gout medicine. I mean, that seems absurd, but it works. Right? So there's lots of medications you can sort of repurpose if you understand the molecular mechanisms and put them in the right place at the right time. And again, I don't know what other doctors recommend. I have no blooming idea, nor do I care. Because I don't want their opinions. I'm going to go to the research and figure out what they do.
I know that you're concerned of people taking too much of these pharmaceuticals, therefore you don't give any of your suggestions on podcast or anything. Are you planning to come up with a thing? I thought you had an application. Is it still live?
So the answer is we had to take the app down because my IP attorney is like, what? It's not copyrighted or trademarked or patented or whatever they do. I'm like, no, we just put it up there for the greater good of humanity. So we had to take it down until that sort of gets processed. But no, I go out of my way, you're correct, to not give drug dosages or suggestions because I don't know who I'm talking to, right? I have and I don't want someone to hurt themselves. So if I use names of drugs, they are more than, they can go to their physicians and have a discussion. Is that reasonable? Is that not reasonable? Alternatively, I see a lot of patients via telehealth and they send me all of their medical information. I look at labs, histories, this, that, and the other. And then we discuss pros and cons of various agents because I need people to know what they're getting themselves into and what dose is appropriate for them and their condition.
Then when you have a patient, are you treating them for anything else? Let's say like if they have a high cholesterol, meaning like...
So let me answer the question for you. I am no one's primary care physician.
I didn't want to ask like someone healthy comes to you, but in their blood markers and in their, whether the cholesterol is high, whatever is this. So you manage these medications and supplements around that, yeah? To reduce that.
But I will tell you that usually people come to me, with their list of medical problems and their labs and what their physician has put them on. And I'm not going to necessarily play with the physician's medications. What I will say is you're on a statin. Have you considered such and such as an alternative? Right? Or, okay, I see that what your physician is doing. Let's make that better. And I send them a list of suggestions. I'm not writing anyone's physician orders because I need them to go back to their primary care physician and have the discussion. Do you think that these things would be compatible? Right? Because, I have charts on people, but I am the longevity physician. I am not their primary caretaker. You know what I mean?
Yeah. Oh, that's a good way, actually. So you don't totally take a client and then organize everything. You kind of go hand to hand with their primary or whatever physician that they're working with.
Mm-hmm.
What else you would suggest to audience to do?
So good question.
But the book is like, I think that, I'm going to keep emphasizing. I normally do not do that. But whomever are listening to us, and it's going to be in Turkish too, they have to get 2 books of yours. I only have 1 because all these stuff that we discussed, this is such detailed. And can you explain how you grade these supplements? Because we didn't say about that. That's so important.
Oh, sure. No, would love to. So I call it the Kaufmann rating system because I did it. All right. and it started with the idea that, okay, you age in these categories, right? And then I would say to myself, well, how do you know what something does? Like, I would ask random people, oh, you take fish oil, or you take this, or you take that. Well, why? And the answer was always crazy. The answer was always because my mother's grandmother's aunt told me to do it. And I'm like, that doesn't make any scientific sense. So what I did is I would take an agent, whatever it was. We'll call it Agent X. And I would just read everything I possibly could about it, right, in the scientific literature. And if it had no evidence that it did anything in any category, it would get a 0. So, for example, if you looked at DNA as category 1, and there's no evidence of anything, it got a 0. If there was evidence in a test tube, in a culture, that sort of thing, it got a 1. If there was evidence that it was beneficial in rodents or any mammal that wasn't human, it got a 2. And if there was evidence in people that was beneficial, it got a 3. And I did this for every category. So now every agent that I look at, and they're all over my website, comes with a 7-digit rating number. Tells you exactly what does what in what category. The only issue with that is that they're very conservative, because if we haven't asked the question, if science hasn't said, well, does X do X in people, I have no way of knowing, right? So what happens frequently is these numbers get better over time as I revamp them, because the studies are getting done. But so people always say, haven't you read the journal of whatever? And the answer is, I can't know everything about 50, 60, 70 agents at all times. So I sort of like go back and I revisit. So the numbers sometimes get better, but they never get worse, because once a study is done, you're like, oh, that's pretty cool. But what I do is I use these numbers to help create protocols to make sure that all of the various aspects of aging are sort of addressed. And that's the gist of the numbering system.
That's kind of crazy. You did for how many supplements or molecules that you analyze in your books?
I think I'm up to 50 supplements and maybe 12 medications at this point, something like that.
The 12 medications are in it as well.
So the medications are not in the books. The numbers are going to be put on the website in the next week or so.
Oh, that's great.
We got it copyrighted, so I can now put it on the website.
Oh, that's amazing. You shared the supplements, that the baseline things that people needs to take if they don't want to take anything else. Do you have any lifestyle suggestions to people? Because you're the cellular medication supplement person.
So what I do is essentially I talk about things you should do every day, every week, every month, etc. So every day, diet and exercise. I think that exercise is like the key to life. If you're not active and busy and moving, everything falls apart. So in terms of lifestyle, I just, pick something. And I think that both cardiovascular and sort of compressive activities are extraordinarily important for tissues and cells. So I always impress upon my clients, something that raises your heart rate and something that has compressive ability, weightlifting or something. And then people love this. Every week I tell them that they should get a body massage.
No.
Because it increases blood flow to your skin, increases blood flow to your muscle. It's physiologically relaxing. It's so beneficial. And then monthly, that's when we get into exosome infusions and other infusions and that sort of thing. But in terms of lifestyle, the answer is just live your best life. Enjoy it. Have fun. Live it to the fullest. And as long as you don't kill yourself, it's going to be great.
So give me one natural supplement and one medication that you cannot live without.
Astaxanthin has to be my most favorite supplement. Medication. Oh gosh, there's so many of them.
Pick one.
Oh gosh. It's like asking to choose your favorite child. That's really hard.
Let's say that, you ended up in an island and everything is...
It's funny you should say that, because when I go, I do a lot of like high altitude hiking, and I'm always like what to take on high altitude hiking and what not to take. But you can't mess around with your glucose levels too much when you're hiking. So that sort of rules that stuff out. Gosh, I have to say the Flozins, I guess.
Okay.
Because I am a junk food junkie, as we have pointed out. And I think that my day is not complete unless I take a Flozin. And what you might find entertaining. So this, I do things in stacks. So this is my morning pile that I have not taken yet, which I will. This is my medications. And this is my afternoon pile. So within my thing, I've got, oh my gosh, so many different colors, shapes, and things. It's hard to pick a favorite, but I think if you make me do it, I'm going to go with the Flozin.
So that you can enjoy life.
Yeah.
I think it's so much worth. So you have the Club Exosome in Vegas, and it's up and running, and people can... we're going to add all these things to our show notes so they can go there without needing to hide from FDA or anything. They can just go there and become a member and have their exosomes.
Yep. Yeah, the website is clubexosome.com. It's run by all the paperworky type stuff, and the organization is done by my partner, Steve McCain. He's an ex-Olympic athlete, just a great human being. Yeah, and we sort of set this up to help people that wanted access to exosomes that get it. So we do it generally every quarter in Vegas, and we try to align with some of the big meetings. So we tend to do it during A4M. We'll do it during RadFest. Otherwise, we just do it when I'm available. But the dates are usually on the website.
Okay, and then you're so generous of sharing all the informations that you can only, if you wanted, you can only have patients coming to you and charging them money, but you have it on your website. And what's the name of your website?
So website is kaufmannprotocol.com. And all the charts with the numbers and the explanations and everything is on there.
And your books are on Amazon.
Correct.
Yeah. And do you have your favorite supplements that is suggested meaning the brands on your website?
Yes.
So people can, without needing to go crazy to find the correct supplements.
That is correct. What I don't know, however, is they're all American links. So I'm not sure what your Turkish audience will be able to get from there.
But, they can still, at least my friends and my people around me, that we must have access to whether order things to Europe, to England, to America, and somehow we figure out to bring them in. This is life. You bring it from Japan, we bring it from US. We figure out a way.
That is fair. I know my mailbox always looks like, I work at the UN. I get from South Korea, from Japan, from Germany, all over the place. It's fantastic.
I think we shared all the information people can reach out to you from, correct?
Yeah, I think we did.
Thank you so much. That was just I have now I'm going to go back and read the book because now I understood the concept, and it's not easy to understand it just listening to two people talking among each other. Now I was able to get it. Thank you so much, Sandra. You gave me 2 hours of yours, and it was a delightful conversation because this is an interesting podcast for me that it's really laying the baseline, the really needed information of a person needs to know about their physical system, cellular system, obviously, but about their own body. Then, therefore, they can decide which parts they want to focus. They don't need a doctor, let's say. They can just pick and choose, or wherever they're weak at. Let's say that if they have a heart problem, they can do it. Thank you so much. It was wonderful.
My absolute pleasure. I look forward to having you have the conference over there, and I get to come. I'd be so excited.